we received a young drone operator. She was preparing a drone for arming it just before a mission, and the lithium battery exploded. It basically burnt and peppered her face, her upper chest, her arms, her legs. It was very disfiguring. She was in a lot of pain, but would not even cry. We explained to her what had happened and said we were going to have to take her to theatre to do burns work. And we said she wouldn't lose any fingers. She would keep her nose and ears, but she was going to be grossly disfigured. One thing she said was, look, I don't care if I look like a monster. Just get me back to the field so I can get rid of the monsters.
This is Beer 30, a podcast that connects badass people and shares their experiences over a cold one. Kick back, relax, and enjoy the show. And if you like it, don't forget to leave us a review on your favorite podcast platform. Let's get started with today's episode.
Welcome to another episode of Beer 30, brought to you by UF Pro. I am your host, Tanner Denton, and today we have a very special guest, Craig Jurisevic. How are we doing, Craig?
Perfect. Thanks, Ian. Thanks for having me on the show.
Yeah, absolutely. It's great. Great to actually have you on. I know we've been talking for a little bit, but we finally got you on, especially since you're on the other side of the world from me. But it's great to have you on, and I would like, if you can, just sort of explain to the audience a little bit about your background and what you have done in the past and what you're currently doing.
Okay, so as you know, my name's Craig Jurisevic, or I've been often called Jurassic or Doc. But my background is, I'm currently a cardiothoracic and trauma surgeon in Adelaide, South Australia, and I am in the Army Reserve. My background is, basically, I always had an interest in trauma surgery and combat surgery, so even in my junior years, I wanted to head out and get as much experience as possible, which initially led me to working in Israel and Gaza back in 92, 93, during the first Intifada. I went there as an independent, non-Israeli, non-Jewish citizen, and so I was actually an Australian citizen, and I served in a trauma hospital and with Israeli medevac teams, where I got a lot of my combat training and experience. I was a lifelong shooter before that and continue to be so I had a lot of firearms experience. Then I went on to continue training in cardiothoracics and again volunteered to help in a conflict called the Kosovo conflict, where I worked in refugee camps and then eventually at the front line with the Kosovo Liberation Army, training and actually in combat roles and working with US Special Forces. Then back to Australia and finished my training and joined the Australian Defence Force and served in East Timor and Afghanistan. And for since the beginning of the war in Ukraine, I've been working with the Ukrainian military in a medical and military capacity up until about 8 weeks ago, and which brings me to Australia now, where I've just retired from medical practice to focus on volunteer work, military and medical training in the field.
That's awesome. I mean, I guess I should start from the beginning. How did medicine become your path? How did you decide you wanted to do medicine?
Well, ever since I was a kid, I always felt like I wanted to help people. I enjoyed it. My mum was a psychiatric nurse, a mental health nurse. She came out as a refugee from Yugoslavia, taught herself English, put herself through nursing school here in a strange country, and had a passion for helping people. And as we kids were growing up, we spent a lot of time at the hospital picking her up and waiting for her to finish work. So I grew to love helping people. And my dream when I was younger was to always go and work in a third world country and work with those who are less fortunate. But I just love medicine, and that's how I initially started. I was always going to be a doctor. And yeah, that's how it started. It was a passion, a vocation.
Yeah. Is there sort of a split point that whenever you get into your medical career that you decided, I want to go into the military to do this, or you can go the opposite direction and say, hey, I want to stay and help civilians?
Well, the motivation is mixed, actually. A lot of my motivation to work in conflict zones and go down the military pathway is from my grandfather, who was my mum's father, who was a Yugoslav partisan in World War II. He was quite well-regarded and renowned, and he was captured and spent 2 years in Dachau until it was liberated. He always spoke out for what was wrong and always stuck his neck out to help those in need, even if it put himself at risk. So I modeled myself. I think it's genetic. It was passed down from him to me to stick your neck out and be an idiot and try and help people when most people wouldn't. But I always had an interest in the military side because of my family background. And I've always been a sporting shooter and interested in shooting, both pistol, rifle, etc. So I was naturally drawn towards the helping those in conflict zones. And for that, I ended up training in trauma and cardiothoracic surgery. So I was always drawn to it. And I think all I can put it back to is my family history and the influence my grandfather had on me.
Yeah. What was there something specific that actually drew you toward what you said, trauma and cardiothoracic surgery, or was it just something you randomly picked?
No, I picked. I actually started off as a general and trauma surgeon. When I say trauma surgeon, in the US and Europe, a trauma surgeon means bone surgery, orthopedics. In Australia, it means general surgery, the abdomen, blood vessels, a bit of everything. So I was a general surgeon first, and I was always going to be I wanted to work in the military sphere in combat zones. And then I thought doing heart and lung surgery on top of that would make me a more rounded surgeon. And that's how I got into cardiothoracics. But I've always been at heart a conflict zone combat surgeon, and cardiothoracics is what I do back in Australia.
Okay. So I guess you had already built a successful medical career, but eventually found yourself treating casualties in some of the world's most dangerous places. I guess we could start at Israel or Kosovo. Is there a specific time or I guess tell us a little bit about your experience in Israel?
Well, I first went to Israel in January 92 because I wanted to get hands-on combat, a combat injury experience. And nothing much was happening in Australia, obviously, or the rest of the world. And I was always quite restless and needed a bit of excitement. So I went to Israel with the help of a surgeon who had contacts there. I was based in southern Israel, Ashkelon, right on the border with what was the Gaza Strip, which was an occupied territory back then. The politics was very different back in Israel. Then I don't want to get into politics now, but the mindset of the people back there in Israel back then was much more geared towards, they were looking towards the end of the fighting and a peace and a two-state solution. So things were looking much more hopeful. Whilst I was in Ashkelon, in the Barzilai Medical Center, I treated a lot of casualties, Israeli military, Palestinian fighters and Palestinian civilians, because there was a lot of conflict going on in the First Intifada. And then one day, treating someone in the ED room, one of the army medics, I asked him what routine he used to go and pick up injured soldiers and civilians in Gaza. And he said, we do this, we go in armored convoys, zip in, pick up the injured. Occasionally, they would go to the Gaza hospital to pick people up and bring them back for specialist care. He said, it's pretty tricky, but do you want to come? And that was my introduction to working in Israel with the Israeli Defense Force, not under contract. I just said, sure. And he said, can you use one of these? And he had an Israeli Galil rifle, and the other guy had an old M16 A1 or A2, I can't remember. I said, sure, I've got something similar back home. So 2 days later, I was starting doing medivacs probably once or twice a week with one of the armored battalions. And that's where I don't want to go into it in too much detail here because of the political aspects, but that's where I got most of my in-the-field combat training, from fire and movement drills to a whole lot of other things, dismounting, mounting, CQB, etc. And it was all aimed at retrieving injured civilians and Israeli soldiers, but predominantly injured Palestinian civilians and fighters.
Was there anything specific that really sort of stood out whenever you were serving on the medevac teams near Gaza?
Well, there was. It was the attitude of the young Israelis back then. As you know, they had national service. But back then, I was 26 and a bit. So I was actually a bit older than the younger soldiers. But the younger soldiers, at heart, they were more about looking after their fellow soldiers, but also trying to pick up the injured civilian or even the injured fighter and bring them back to safety. So they were focused on a really humanitarian job, even though they were military. It's quite an interesting dichotomy, really. So that's what struck me. And they were very hesitant to return fire. It's an interesting dynamic. They basically wanted to help people, but they realized to do that, they would have to defend themselves and use military tactics. But that struck with me. That actually the motivation was very non-aggressive, if I can put it that way.
Yeah. Wow. How did Kosovo differ?
It was completely different.
Yeah.
I went to Kosovo as a surgeon working with an American group called the International Medical Corps, who provided surgical teams. I ended up in the east of Albania on the Kosovo border, where there are about 100,000 refugees in refugee camps, and I ended up becoming the surgical coordinator for all the refugee camps and the local hospitals. But to cut a long story short, things turned sour. There was a lot of corruption and issues with the hospital system receiving the refugees in that. I won't go into it now, but there was a lot of conflict. And at that time, the Serbs closed the border, so then the refugees would have to come through the front line up in the mountains. So at that point, I decided I would go with the Kosovo Liberation Army, who are basically just civilians with guns, very little training, and try and treat the injured at the front line, both the KLA and the injured civilians. So when I got up to the front, I did a lot of training, because one of the issues there was that these were volunteers with their hearts in the right place, but they had virtually no medical training. So I started training them and took part in missions to rescue injured civilians behind Serb lines, and got very involved with local a U.S. Special Forces team who were taking coordinates from the front to direct the NATO bombings.
Wow.
And it was very different. The good thing about Kosovo is that I was there for the end of the war and the liberation of the country, which was very rewarding. I was pretty exhausted by the end of it, though.
Was there a moment that permanently changed how you viewed trauma care sometime in Israel or Kosovo?
It was in Kosovo. I learnt and I taught that you can do a lot with very little, in that at the front line, it was a 2,000-meter mountain. We had 1,800 KLA fighters with about 10,000 Serb forces opposite us, and I was the only doctor at the front. A lot of the others, doctors and medical people, stayed back from the front because obviously it was very dangerous and they weren't trained or experienced in it. So we set up a small surgical unit in a shepherd's cave at the front line, and we resupplied by walking up and down the mountain, carrying everything you could in just a backpack. So I worked on my own with one of the KLA, a Kosovar nurse, a male nurse who actually originally lived in the UK. And we did everything from putting tubes in the chest to completing amputations of legs that were partly blown off to and stabilizing patients in the cave with basically just ketamine, a little bit of morphine, and that's about it. And we did something pretty impressive or incredible work up there to stop bleeding because we realized we had to stabilize them to get them down the hill, and it takes about 8 hours to get down the hill with a stretcher. And you were often targeted by Serb patrols and mortar teams. So we did pretty well everything we could on a shoestring in the cave. And that taught me then what we now know as damage control surgery.
Okay.
And so back in 1999, damage control surgery, or the idea of a Roll 2 unit, was something very new and wasn't actually in place in most NATO countries, I don't think. But so that's led to damage control surgery for me. The Norwegians had a little base, a volunteer base in Albania down on the other side of the front, and they were doing damage control surgery as well, which was an eye-opener for me.
Yeah. Did you ever have first patient or anything like that you could just never forget?
Well, there are quite a few of them. Oh, there's one I could never forget. A young soldier at the front in Kosovo who was difficult. He had lost one leg below the knee, and the other was just hanging on below the knee, and he's brought to us. And he wasn't complaining, he wasn't crying or screaming. He was a Kosovar, probably about 22, and he was very close to death because of blood loss. And when they brought him in, I remember vividly, I said, "I've got a bit of morphine left. Can I give you some morphine?" And he looked around the cave, which was about the size of this room, about 10 feet by 10 feet, and saw a few other injured. He said, "No, keep it for the other guys." So that's not an operation, but I remember he was obviously in excruciating pain. So I remember him vividly, even though I didn't do anything to him. I just left his tourniquets on, and plumbed him up and sent him down the field. But he was near death and just wanted to give the morphine to his friends.
That is incredible.
And I've seen a lot of that in Ukraine.
Yeah. Wow. Did you have any sort of lesson learned early in those Israel or Kosovo days?
You mean medical lessons?
Or life?
The thing you learn early is that you're no good to anyone if you're dead, especially as a medical doctor. So you have to be able to defend yourself and protect your patients. But first of all, you have to be able to protect yourself, then your patients, and everything else is secondary. That's what I learned very on. I mean, everyone's taught that, but I learned it in real time. So I always, everywhere I go now in any conflict zones, I'm always completely independent in terms of my own security and protection, weapons handling. And I often get a lot of young guys, young surgeons at Gaza and young men, male and female doctors saying they would love to go and help and do the sort of work I do. And I tell them, unless you've had the training and you're very confident in your own skills, don't go, because you'll end up either dying or being a burden on the people around you.
I could absolutely see that, because it's one thing to know medicine and surgery, but then when you're under fire or artillery it seems way, way, way more hectic than it would be just in a civilian setting.
Absolutely.
So, transitioning into your formal military service, why did you join the Australian Army after already being an experienced surgeon?
Well, I didn't want to. I mean, everything I've been doing up until Kosovo was as a volunteer on my own. And I really didn't want to join the military, because the Australian military or any formal military, because I felt that there would be too much red tape and it would take away the freedom of where I could go and what I could do. There would be obviously significant legal and political restrictions. But I had a lot of friends in the military, and in Australia, the medical corps is about 90% reservists or civilians who give their time, because we don't have any major military hospitals in Australia and military medical training. So a lot of my friends who I worked with were actually reserve in the Army, Air Force, and Navy. They were trying to get me to join them for years and years, and I finally buckled. And I buckled at the age of 40, or was I 41? I can't remember, back in 2006. But then I also thought, fair enough, I want to use my skills so I can help our young soldiers if they need me. Because I had 3 sons at that stage too, and they were young, and I thought, I should go to help support our guys. So I didn't join the Australian Army until I was 40, almost 41.
Oh,
so
wow.
it wasn't I didn't jump at it, but so I joined the Australian Army, and there was a desperate need for trauma surgeons with experience. And at that stage, there weren't many of us around, because there hadn't been many wars, and I'd had the most combat and medical experience in that area for probably of anyone in the country. Anyway, so within 6 weeks, I was sent to East Timor as the head of the surgical team to support our special forces. And then in 2008, we went with the first surgical task force to Tarin Kowt in the Oruzgan province on the Camp Russell, which is a combined US-Dutch base.
Wow. What was East Timor like?
Well, East Timor was interesting. There was not much in the way of combat or happened in East Timor. It was mainly civil unrest in 2006. East Timor achieved independence in 1999, and that's when the Interfet, the Australian force, went across for the first time. There were some combat events then, but in 2006, it was basically civil armed disturbance with groups attacking government headquarters and police. So we were sent there to stabilize that. So that was a fairly low-key affair. I mean, interestingly, my first deployment was with a surgical team on a ship. So we were sent on one of the ships, which supported the SAS, our special forces and commandos. And so basically I was operating on a ship, and we had to dock at the port, and the Navy was responsible for the security of the port. So back then, a lot of the Navy personnel weren't that familiar with weapons handling. They were, because they all trained in it, but they weren't up to patrolling. So once we had a 24-hour roster running, within a day or two, they ran out of Navy people on the ship to patrol. So I ended up doing shore patrols with one of my medics and a Navy officer, which was quite funny. I was a mate? No, I was a captain then, a captain now. So I had a captain, a corporal, and a naval officer patrolling the streets. Just patrolling the shore outside the front of the government house. I knew what to do, but I don't think the other guys did. It was something different. It killed the time. So East Timor was a low-key affair. It was a low-key affair, yeah.
Okay. Afghanistan was obviously a very different conflict. What stood out there?
Well, I'm sure you guys are all well aware of what's happening in Afghanistan. We were in a forward base. It was a base of we had about 900 on the base. At that stage, it was mainly Dutch soldiers and Australian Special Forces. We had a contingent of about 300 Afghan National Army within the base and a small US forward surgical team a kilometre down the road. We were tasked with running the Role 2 surgical unit there. So I accompanied a team as I was the general surgeon. We had an orthopedic surgeon, an anaesthetist, and a team of nurses and technicians. And they ran a very tight ship. It was a very well run, state of the art Role 2 frontline surgical unit. We had a moderate number of Dutch casualties, but at that stage we were accepting civilians, so we had a lot of civilian casualties, and also the Taliban fighters who came through. The biggest security risk was the occasional mortar attack. No, sorry, that wasn't the largest, biggest. The biggest security risk was the Afghan National Army and friendly on friendly fire. And there were incidents during the year and the years around when I was in Afghanistan where Afghan National Army soldiers would kill Australian soldiers or NATO soldiers. So that was probably the largest threat in base. Yeah, but it was a good time. We treated lots of people. I ended up training some of the SAS and commando medics. Well, my team helped train them. We got them into the operating room. And then we would they took us out to their range. They had a separate range quite closer to Taliban territory. And we just played with all their weapons, from the Barrett 50 cal to a whole lot of other things. So my medical team enjoyed it. I had a few competitions. We used to have unofficial competitions with one of the guys there. So I couldn't keep up with them with a 50 cal. They used a 50 cal with the high explosive incendiary rounds, shooting at destroyed cars at about 1.3 kilometres, which I could hit, but then they were taking it out way beyond that. I couldn't keep up with them. But it was a good deployment. It was a good deployment. One thing that stuck with me from that deployment was one patient, an Afghan shepherd who had been out in the mountains all winter, and he came down to our base in the spring. He was about probably 60 years old. What had happened, he had sore feet, so we had a look at them, and what had happened, he had such bad frostbite that the front half of his foot died, and by the time he came to us, his foot was actually mummified. He couldn't feel it mummified. Anyway, so we treated that. But when we finished treating him, through his translator, he said, "Thank you very much. He called us you Americans. He assumed we're all Americans, and foreign people are very lovely and sweet, but you're going to lose." He said, "The Russians came, they killed everyone and everything, and they still lost." He wasn't saying it in a negative way. He was just making a pretty stark observation. Yeah, so that really stuck with me.
Wow.
That even though we all played by the rules and treated everyone nicely, we were definitely going to lose because the Russians, that's what his words, the Russians killed everything and everyone, and they still lost. Well, they still left. Yeah.
Wow.
You may not want to put that on because that may be a bit contentious.
How much has battlefield medicine improved over the years of your career?
Oh, incredibly. Well, I think the biggest. Oh no, let's go back. I think what I noticed when we go back to Kosovo, there was in Albania, just near the front line, there was a Norwegian volunteer group called NORWAC, NORWAC, who sent surgical teams around the world. They're in Lebanon, West Africa, and they set up a little surgical team in Mosque Hall in a town called Krume, Krume. And they brought all their own equipment, and there was a team of Swedes. The lead one was Dr. Eric Foss, F-O-S-S. He was a cardiac surgeon. And they had disposable everything, fantastic equipment. which it sort of struck me in the middle of nowhere. And they were performing, and I assisted them in a damage control surgery where I'm sure you probably understand damage control surgery, where you have to stop the bleeding, stop the contamination, fix the fractures, stabilize the patient, and ship them out to the next level of care. They were doing that back in 99. And I didn't realize how groundbreaking it was until I joined the Australian Army and saw that was continuing on. So I think what has changed is that the damage control surgery from a surgical point of view has changed as resulting in significant survival benefits. The techniques haven't changed that much, but the protocols are excellent. What has changed is the tactical combat casualty care, first aid at the point of injury, but we'll probably get onto that later. So the surgery itself, damage control surgery, is pretty simple and basic and straightforward, and it can be reproduced anywhere in the world. So the fact that everyone is doing the same thing has also improved casualty care as well.
So let's move a little forward. After Afghanistan, let's just fast forward to 2022. What motivated you to go to Ukraine?
Well, the same thing that's motivated me to go to other places. I saw there were people in it. Or basically what I thought was, I put myself in the situation of the Ukrainians. And if we in Australia were invaded and being attacked with thousands killed, I would like someone with my experience and skill to come and help save the lives of my 3 sons or my children. So I figured, as I have in the past, I said I can put myself out for a few months, leave my comfortable life in Australia. My kids are safe here. My family is safe, and go and help and hopefully try and save some other young men and women and keep families whole. So it's pretty as simple as that. And I also thought from a geopolitical and strategic point of view, I looked at this conflict and thought, I have to help, because if Russia wins, that shows that the autocratic aggressors elsewhere can win, and which would mean that countries in our region are in threat as well. But my main motivation was go and help. I wanted to do for them what I would like somebody to do for us if we were in the same situation. So it's about as simple as that.
Yeah. What were your expectations going into Ukraine versus reality?
Well, when I went into Ukraine, I had fairly realistic expectations based again on my Kosovo experience. When I went to Albania, Albania was a failed state, former communist state, and the state of the health system and the hospitals was terrible. The standard of operating care was not very good. So I sort of half expected that going to Ukraine, working initially in the civilian side of the medical system, I sort of knew what to expect from an Eastern European type of setup. And I wasn't too far from the truth. But so I expected that the civilian side would be sort of Eastern Bloc, but I had no real concept of what the military side would be like, because this country had just been thrown into war. Admittedly, they were invaded in 2014 and had a lot of experience from that, but they were thrown into a full-scale war. And I actually had no idea how they would have structured their medical units, frontline medical units, and how they actually ran them, because I thought, I went there in August, only 5 months after the war began. How would they have been able to set things up this quickly on such a large scale? I had no idea what to expect towards the front line.
Wow. Can you explain how some of these mobile military surgical hospitals operated?
Yep, absolutely. It's a very good system. When they say they're broken, the Ukrainian military medical division is broken into military mobile surgical hospitals. And that's exactly what they are. They're actually not mobile. The actual structures aren't mobile. The personnel are mobile. And this is a very important point, which is not really, we don't have a similar thing in the West. What they do is they go to roughly 25 to 30 kilometers from the front line to set up what we call a Roll 2 or damage control hospital. They find a pre-existing hospital or a hard structure building and set up there. The first one I went to in 2022 was in a town called Druskivka, close to the Bakhmut front. There was a small 100-bed hospital, a civilian hospital, which the army moved into. They had, and this is typical of the Roll 2s, they had a small casualty receiving area, which is the old emergency room, 2 resuscitation rooms, 2 operating theatres, and a 4-bed ICU capacity only. Because the idea was to roll people through as quickly as possible and send them straight on. They had about 100 beds in the hospital, and the civilian doctors used the hospital and the other part of the hospital for the local population. And that's pretty much the setup in a lot of the Role 2 units. So the military occupy pre-existing hospitals where the fight is and run it from there, which is a really good model, especially now, we'll probably get onto in the era of drones and where your Role 2 is actually subject to massive attack. When we plan in the West for a Role 2 unit, we don't plan for our Role 2 units to be under attack. That's why we still use tents, which is ridiculous, or even HESCOs are ridiculous. So, but they find buildings, and if the building is damaged, which ours were quite often, they find another hospital, another building. So they are actually a true mobile surgical team.
Wow. What kind of injuries were you seeing most, sort of being close to the front line?
What changed from 22 to when I was just there, or when I was last operating last year? Initially, the injuries were all from predominantly artillery and small arms, so massive blast injuries. To give you an idea, about 30% of the patients had at least one limb severely damaged, plus another area damaged, so abdomen or chest. So most patients had one or two limbs severely damaged, requiring amputation or vascular work, abdominal penetrations and chest penetrations, and about 15% of patients had 3 limbs injured, abdomen, chest, and head injuries. So, and this is combined with penetrating injury, blast, where a large amount of soft tissue and muscles blown off, and burns. So probably the worst, and so those injuries are very similar to what we saw in Afghanistan from armored vehicle drivers who were struck by IEDs. Massive tissue loss, fractured bones, burns, penetrations. And this was your average patient. So you could get, well, in the Druskivka, the first time we would get roughly, at the most, you could get about 300 casualties a day, and about 50 of them were like this. So massive injuries. We usually get, when we grade somebody when they come into a trauma, we give them an injury severity score. We wouldn't even bother over that because it'd be way off the scale.
Oh, wow.
And so was that due? These are thousands of patients, yeah.
Yeah. Was that due to just the type of warfare that was going on, or is it just due to the nature of progressing in, I guess, the arms that we're using over there, or like you said, drones or artillery?
No, initially, the injuries were mainly from artillery, mortars at the front line, because it was quite a static front line with a lot of trench fighting. So these were injuries from high explosive ordnance. Oh, nothing new, just lots of artillery.
Okay. As
the war progressed, especially, and the drones took over, the majority of the injuries, especially now, are from drones, drone explosives, kamikaze drones, much less from artillery. But yeah, so that has changed over the last 4 years. One other thing I saw, which I hadn't seen before, is the use of white phosphorus. The Russians would use white phosphorus on civilian areas, and those injuries are horrific. The white phosphorus burns through your clothes, through your flesh very quickly, so you have to rip off the clothes and douse everything in moist towels. They would often use white phosphorus in the winter months because they realized that the first aid was to strip the clothes off, but you couldn't really do that completely because the patients would freeze to death. So once they get into hospital, you have to amputate, clean take as much flesh off as possible to get rid of the white phosphorus granules. But yeah, it's terrible. And it's against the Geneva Convention in civilian zones too.
Did you have the proper equipment initially to treat these wounds from white phosphorus, or did it come in and you're just like scrambling?
Well, the white phosphorus I saw was actually not at the front, but in the civilian arena around the city of Dnipro, where the big Role 3 hospital is, where their patients go from the Role 2 to Role 3. And they treated them really well at the front line, at the point of injury. But you don't need a lot of equipment. You need to keep the wounds moist, and there's certain chemicals you can use, but you have to debride or cut the tissue away before the white phosphorus gets through the deeper tissues and into the bloodstream. So it's a race against time. I mean, they're horrible injuries to treat. Horrible injuries. Yeah.
Jeez. Has drone warfare fundamentally changed battlefield medicine?
Absolutely. And I can give you a perfect example which happened only recently. I'll speak of it in a later example. I was this year And last year, most of what I was doing was training the separate special operations regiment in the east. Because of the drone warfare, there is basically a kill zone which can be up to 10 or 50 or 10 kilometers wide all the way along the front line, where it's almost impossible to move in numbers greater than 2 or 3, and everyone's aware of that now. The injuries, blast injuries, but the way drones have changed care of the casualty is that they can supply blood products, medical equipment to those injured behind the front line. And one of my tasks, other than the tactical shooting, CQB and trench fighting, etc., was teaching tactical combat casualty care, and I would teach advanced medical techniques to the special operators so they can do things behind the lines that basically doctors and trauma surgeons would be doing, because they need to keep each other alive. So one example, one of our teams went out on patrol, went out on a mission. They got stuck behind lines in Pokrovsk. 3 were injured. They couldn't get out for about 3 days. So they were flown in blood, plasma. They were flown in pelvic slings by FPV drones. We communicated with them all the time to tell them if what they were doing was correct. It was the team that I trained, so they could put in a chest tube. They knew how to put on pelvic slings, and they did a fantastic job and kept 3 people alive for about just under 60 hours before they could be evacuated at night. So drones are actually changing the way we actually treat people behind enemy lines, and actually we're allowing the soldiers themselves to treat themselves. And you mentioned the medical evacuation drones. The Ukrainians have built the termite system, or TRMIT, which is a track-based vehicle, which is autonomous or controlled, and you can mount a 50 caliber machine gun on there, or you can mount an evacuation stretcher, which is armored, and they've been using those to retrieve injured soldiers as well. That is good, but it's only on a small scale.
Yeah. Are soldiers surviving wounds today that would have been fatal 20 years ago?
Exactly, they are. Let's go back. They are, absolutely. We were in the frontline Roll 2 units that once the casualties, they had, let me go back a bit. The medics are so well trained, the average soldier is so well versed in the use of tourniquets that we're getting soldiers brought to us who shouldn't have survived and couldn't have survived 30, 40 years ago. Those with 3 or 4 limbs blasted off, abdominal injuries. And obviously, a lot of these cases, these patients don't survive. They're unsurvivable, but they make it to us at the Roll 2 alive, which is a real testament to the frontline first aid care.
What impresses you most about the Ukrainian forces that you were training?
Their professionalism, their willingness, or they're the best students I've ever had, because they know everything they learn, they may have to use very quickly, very soon. And it wasn't uncommon, especially this time when I was there, that you'd run through, I ran a 4-day training program about CQB shooting, etc., with other foreign operator trainers. It wasn't uncommon that you'd be halfway through a training course and you teach them how to do special TCCC, chest tubes or whatever, and they'd be called away to do an operation, and they'd be using the skills you taught them, either the combat skills, shooting skills, whatever, and medical skills within hours of having the training session. And then they'd come back the next day for more training, occasionally without a member. And my role over there was, as a military trainer, was to try and get the special operations replacements up to scratch so they could work with that team and go out on patrol as quickly as possible. I mean, there's only so much you can do, but they're fantastic students. They're like sponges. And if they don't understand something, they'll ask you until they get it, because they know they may need it to help themselves or their comrades.
Wow. Let's move away from the tactics and medicine into the mindset. How do you mentally process seeing all this severe trauma for decades?
Well, you develop technique, you can compartmentalize. You don't become emotionally numb to it. You just learn to put things aside. And this is where I try and explain to people who don't do medicine or combat medicine or anything, the graphic nature of the injuries, the gore, you can get used to. in any job, you have something that is difficult and you just get used to it. So it doesn't affect the blood and the gore and the damage doesn't affect people who are seeing it all the time because they have overcome it, they've adjusted to it. So if you put anyone, even a non-medical person in that situation, initially it'd be awful, but eventually they will get used to it. The emotional side is a little more complex. I find it actually easier working in combat zones rather than working as a surgeon back in Australia. The reason for that is when you're treating people in your home country, which is not at war, you get to know them. You probably get to know their families to a certain degree. You operate on them and you can make them worse. And then you look after them post-op, so you develop a relationship with them. In combat zones, you don't know the person that has come into your trauma room. And they sort of just become a casualty. And because you're doing life-saving work, you don't have time to think about the emotional side of things. You just get on and do your work. It's a very protocolized way of thinking. So it's actually easier from an emotional view, despite the injuries being horrific and the numbers being massive. It's easier, from my point of view, to work in a combat zone than back home. But it is hard when you have quiet moments. It is hard seeing, hundreds or thousands of young men and women, old men and women, are killed or injured every day. And you have to realize the Ukrainians are doing an amazing job in that they are taking probably 200 dead and up to 1,000 injured every single day since the war started. So as an example, in Australia, we lost 42 soldiers in 11 years in Afghanistan. They would lose 42 soldiers between cups of coffee. Yeah, so they're a very resilient population. And one thing I noticed about the Ukrainian soldiers, and these guys aren't career soldiers, they've just been joined up recently or over the last few years. When they come in, you can have two soldiers side by side, legs hanging off, open injuries, still conscious. They're looking at each other and still talking and encouraging each other. They use almost no pain relief before or after surgery compared to people in the West, and they just don't complain. They're extremely stoic. And that's what I noticed. It was the most significant difference in treating Ukrainian soldiers to almost any other military I've worked with in the world. Kosovo, Israel, Afghanistan.
Wow. So it sounds like it's sort of become routine. So it doesn't necessarily, like you said, you sort of get used to it and go through the motions and do everything. You don't get attached because you got to make it quick and it's coming in so quick. Have there still been moments that will stay with you, even though you're kind of in a routine?
Yeah, I think there are for anyone working in that line of work. There are too many. Which is one? Actually, the one I was thinking of was when I was in Slovianka, last year, 2025, near the front. We received a young drone operator. She was probably 27, and she was preparing a drone, arming it to try and just before a mission. And the lithium battery exploded, and it basically burnt and peppered her face, her upper chest, her arms, her legs. It was very disfiguring. When she came, it was brought into us. She was in a lot of pain. You could tell she was in a lot of pain, but would not even cry. And when we started talking to her, she spoke perfect English. We explained to her what had happened and said we were going to have to take her to theatre to do burns work. And one thing she said, we said she wouldn't lose any fingers or she would keep her nose and ears, which was quite promising, but she was going to be grossly disfigured. And she said, one thing she said was, look, I don't care if I look like a monster, just get me back to the field so I can get rid of the monsters. And that was that's really struck with me because she was going to be grossly disfigured. You could tell she was quite beautiful and quite attractive underneath, but she was instantly disfigured, but she actually did not care about that. She wanted to get back to the front, run the drones so that she could help defend and defeat the Russians. And bear in mind, in the recess room, we have two bays. It's beds stretched side by side, so she could see the guy next to her who had one leg hanging off and was unconscious. And she looked across, and that was probably an even stronger motivator for her. So I remember her vividly.
What motivates you to keep returning?
Good question. I've progressed from my mindset's changed. When I went there initially, I was there as a surgeon for the first 3 years, as well as a military trainer. But I realized that I want to do more than just patch up the injured soldiers coming through. That's why I got more involved in training special ops teams so that basically they could help defend. And I had a force multiplying effect where I could actually help more people, train people who then become trainers themselves. I want to do it because I want to see the war come to an end and the suffering end. And for me, it's a job that's not finished yet. And I've gone beyond that now to doing some strategic work with some of the intelligence units to try and bring the war to an end, because I really want it to stop. And my other driving force is that Ukraine has to win. If Ukraine loses, the world loses. And we don't hear as much about it here in Australia or the US, but in Europe, on the media channels and just social media, everyone's talking about it all the time because they realize they could be next, especially the Poles and the Baltic states.
Wow. How do you think battlefield medicine will change over the next decade?
I think damage control surgery will stay the same, but what will change is the treatment at the front line. You'll have telemedicine, you'll have drone supplies to the injured, and the standard of medical training will be increase across the board from privates up. I don't think we'll be relying on unit medics anymore. Every soldier will be trained to do life-saving procedures. For example, the use of tourniquets in Ukraine has saved more lives than anything else. Teaching soldiers to put on tourniquets properly, and just as importantly, knowing when to release them or take them off is crucial. At the beginning of the war, tourniquets were left on for too long. Now, almost every soldier knows how to do the tourniquet release or tourniquet conversion technique, where you move it further down to save as much tissue as possible. And that's, I think we're going to rely on the soldiers to treat themselves, because evacuation in the area of drones is going to be almost impossible.
What advice would you give young military medics or surgeons?
Young military medics, I would say they are definitely the lifesavers. One thing I teach medics is that do what you think you have to do, even if it's beyond your scope of practice, and because you have to do everything to try and save that soldier's life in the front line. People in civilian life think, I won't do that procedure because I could injure them. I tell them, unless you try this soldier's dead. So if you damage, for example, putting a chest tube in or putting a finger into the chest, if you damage the lung a bit, it doesn't matter. They'll still be alive. You've relieved that tension in pneumothorax. So I think be proactive, save the life, and take risks. I think we're too bound by protocol. So that's what I teach the medics. Surgeons, we're having problems with surgeons now because everyone has become so subspecialized. You don't find people like me who can do abdominal surgery, vascular, all that. So that's the surgical side is actually much more complex. What I do say is if you want to get young surgeons, if you want to get combat experience or trauma experience, go somewhere where there is a lot of conflict, but don't go to a war zone. Pick somewhere like South Africa or a busy trauma hospital in the US where there are lots of gunshot wounds.
Chicago.
Chicago, exactly. Yep.
Yeah. Looking back over 30 plus years, what are you most proud of?
Oh, wow. I haven't been asked that before. Proud of? Proud of myself, you mean? My achievements?
Yes, sir.
Let me see.
You don't need to be modest.
Okay. I'm a good teacher. I'm proud of the way I teach. I teach with passion and won't leave the room until they've learned. So I teach with purpose. Yeah. I'm proud of the way
fantastic. I teach. That's good. That's great to be a great teacher and to have passion in it. If you could leave listeners
about that too with your line of work as well, because you're teaching nonstop. It is exhausting though, isn't it? Teaching. I have a theory that if you're teaching and at the end of a teaching session, whatever you do, anything, weapons training, gardening, sewing, shooting, if you don't feel tired and exhausted, then you haven't done it properly. You haven't given enough.
Yeah, absolutely. Yeah, I mean, after just an 8-hour day of on the range teaching people, I mean, everyone will leave exhausted. That's great.
It is. You know you've done your job, and that energy's gone into your students. Yeah.
Mm-hmm. If you could leave listeners with one lesson, what would it be?
Oh, I think it would be a life lesson. If you think something is wrong and you might be able to help, because it'll be difficult to live with yourself if you don't.
That's fantastic. Thank you for giving that, because I'm going to take that into my own. That's awesome.
Thank you.
Craig, thank you so much for coming on to the podcast. Again, it's great to finally get you on. We haven't had, as far as I can remember, we haven't had anyone as experienced as you and as knowledgeable as you in terms of medical. So it's fantastic to hear, especially with how much you've done over the past 20 plus years, and especially actually being so recently into places like Ukraine. So it's very interesting to see perspective from something like that. So thank you very much for coming on to the show. And as far as listeners, thank you for listening. Tune in next time for the next episode of Beer 30.
So there you have it. This concludes another episode of UF Pro's Beer 30 podcast. Want more information about UF Pro and tactical clothing for professional end users? Then please visit ufpro.com or follow our channels on YouTube, Instagram, Facebook, and TikTok.